start by talking about respiratory failure first. So there's two general broad types, the hypoxemic and the hypercapnic. In the hypoxemic respiratory failure, it's basically the patient's inability to extract oxygen from the air. And that can be due to alveolar disease or say in ventilation perfusion mismatch, would be like in pulmonary embolism. And then in hypercapnic respiratory failure, you have the patient is unable to essentially take deep breaths. And so that can cause the PCO2 to go up. And so in these two situations, you can make the argument for definitive airway management. And these two slides are just kind of a way for you to form a differential. There's certainly multiple causes of hypercapnic respiratory failure. The biggest things that we usually see is in CNS disease, kind of like what the other lecturer was talking about. Somebody who's obtunded, who's an opioid overdose, that's the most common one that we see. But certainly in other conditions also, like in neuromuscular disease, like myasthenia gravis, where they cannot take deep breaths. And in hypoxemic respiratory failure, here's another differential slide. Again, the most common cause of it is alveolar disease, like say pneumonia or acute respiratory distress syndrome or CHF, where they cannot extract the oxygen. So most common reasons that we would intubate somebody is somebody cannot protect their airway. So like the other lecturer was saying, GCS of 8, you intubate. And so people with depressed mental status, people who are at risk for aspiration, needs to be intubated before they develop other complications from that. And then people who cannot maintain their ventilation, say an asthmatic who's starting to tire out, needs to be intubated. Or a COPD patient who is becoming more and more somnolent because their CO2 is going up, probably needs to be intubated. And then if you think that the patient, say like somebody with an epidural who is stable, but will decline or they need to be transported somewhere, should be intubated before they code. Here's another slide that I got online. It just kind of breaks it down to A, B, C, D, E, F for you to kind of look later. So if somebody is in respiratory failure, the first thing that you need to do is assess their airway. Is it patent or not? So most commonly, if you have somebody on trauma who has a traumatized airway, or somebody who's completely obtunded, their airway would open, but they can't protect it because of their CNS disease, and they would require ventilation. But most of the ones that we would see in the emergency room actually has a hypoxemic respiratory failure, say they have pneumonia, CHF, or asthma, they're protecting their airway. And most of the time, all that they would require is oxygen supplementation. But we're going to talk about these people who's going to need the mechanical ventilation. And again, the next thing that you would look for, like he was talking about earlier, is to look for reversible causes, say an opioid overdose who would need Narcan. Then that might be a patient that you can save an intubation. However, sometimes they develop complications like a seizure, and then they will need mechanical ventilation. So this is the overview of the airway that you would assess during assessment of respiratory failure. You need to look for where are they having where they're having problems at. Is it in the oropharynx? Is it in the upper airway? And so airway assessment, so first thing to do is to observe the patient. Is it somebody who's completely obtunded, food coma there? Somebody who's having like a severe asthma exacerbation and that looks very agitated and anxious, or somebody who's choking. Again, if somebody that you see has a trauma and has a GCS of 8, those people are most likely unable to protect their airway, so they will most likely need definitive airway. And then you look into their face and the mouth, and it's going to talk about some of the things that you would consider. Say if you've already made a decision to intubate a person, things that you need to look for are people that are difficult to bag mask. And the reason for that is that these people are difficult to intubate. So if you've got a patient who's difficult BASMAC ventilation, most of the time you're going to need help with these people. They're not going to be easy. So these are people that are obese, have short neck, big beards, people with poor dentition, people with really severe chest deformities, and obviously, you just can't. It's going to be impossible oral intubation. And so the mnemonic for that is moans. And then you then do the Mallampati, which is basically looking at their airway to see how much soft tissue they have in the posterior pharynx. And then depending on how much tissue there are, it's going to be a difficult intubation. So people are considered difficult if they're Mallampati 3 and 4. And then there's another mnemonic of lemon, which basically kind of integrates everything. So there's some features of the face that makes people difficult to intubate. So if they have limited mouth openings, so say you can't fit 3 of their fingers into their mouth, most of the time if you try to intubate that person, you're not going to be able to open it up. Or if their jaw is so small, so say like 3 of your fingers, their jaw length is less than 3 of your fingers, most of the time their jaw is so small that if you try to intubate them, their tongue is not going to fit into their jaw, so it's going to be in your way. Or if their larynx is so superior and anterior, meaning the distance between the base of the neck and the thyroid cartilage is less than 2 finger length. Most of the time, when you try to intubate them, their airway is going to be anterior and superior, so it's very difficult to visualize. And again, they talk about the Mallampati here, somebody Mallampati 3 and 4 are going to be very difficult to intubate. If they've got the moans, the obstructions, if they've got a big tumor, or they have a traumatized airway, they have epiglottitis, they have angioedema, that's going to be difficult. If their neck has very limited mobility, because you need, and we'll talk about that later, you're going to need to manipulate their neck a little bit in order to intubate. If they've got limited mobility, it's going to be almost difficult or impossible to intubate. And if their saturation is very low, it's going to be a difficult intubation because you're going to have really low, very small amount of time before they start to decompensate. Another way to assess for difficult intubation is the thyromental distance. Basically, your mentum all the way to the thyroid, if the length is less than 7 centimeters, that's going to be difficult to intubate, only because most of the time their jaw is small, the larynx is superior and anterior. So these are people that are going to need maybe like backup, so anesthesia or ENT to be with you when you're going to try to intubate these people, or be in the OR, just in case it doesn't go too well. So say if you try to intubate somebody and you've got no backup and you look at this, this is a Cormack-Lehane, basically the grade view of the airway whenever you try to do a laryngoscopy. If you've got a Cormack-Lehane grade 3 or 4, these are almost impossible to intubate. And these are people that you're going to need, we'll talk about that earlier, backup and other ways to try to intubate them. So next is to assess their neck. Is this a person that's got a big, say, hematoma in their neck that could be compressing their trachea or their larynx, or they have a big tumor, a big infection? These are going to be difficult to intubate only because your landmarks are going to be off. Say they have like a big tumor that's deviating the trachea, or they're compressing the trachea and you won't be able to pass the endotracheal tube. And then you need to look at basically their work of breathing. So a baby will have, say, intercostal retractions. And those people that are having that will need definitive airway. And then people that are tripoding because they're trying to protect their airway, like this kid that's got epiglottitis. And then you need to listen to their neck if they have, say, stridor. Those are the signs that there may be laryngotracheal swelling that can make, say, intubation difficult. So there are multiple types of airway, and there's different levels of airway. So you can do the non-invasive airway management, basically passive oxygenation with say a nasal cannula. And then there's the invasive airway management I'm going to talk a little bit more in this presentation. So with non-invasive, say you have a person with hypoxemic respiratory failure that is otherwise protecting their airway and they're alert, they can follow commands, you can try to give them, and if they have intact respiratory drive, then you can try to give them a supplemental oxygen by nasal cannula. And the difference in these kind of modalities is the FiO2 that you can deliver a fraction of the inspired oxygen. So in nasal cannula, the maximum FiO2 that you can give is 45%. And again, the normal FiO2 in the air is 21%, so basically you're just kind of doubling that. If you do a venti mask, you can go up to 60% FiO2. If you have a non-rebreather mask, you can go to 100%. Sometimes, usually it's more 80, 90% FiO2. And then there's something that what's called a high flow O2, that you can deliver also 100% FiO2. And again, these are only used in people with hypoxemic respiratory failure with intact respiratory drive, not useful in hypercapnic respiratory failure. And actually can even be maybe detrimental because in COPD, if you give them too much oxygen, theoretically you can decrease the respiratory drive and they can stop breathing and become apneic. Some of the things that you can use also are the oropharyngeal and nasopharyngeal airways. The oropharyngeal airway, you can only use that in people that are completely obtunded with no gag reflex. And you can basically help open up their airway and help with bag mask ventilation with this. And then the nasopharyngeal airway, you can use that, but the problem with it is that there's really very important contraindication, which is the basilar skull fracture. Because what happens if you introduce this and they have got a fracture, you can push this up into the brain. And then basic airway maneuvers, so the head chin lift and jaw thrust that you hear about in ACLS. And then the bag valve mask, basically the most important thing in management of the airway, because this is a way that you can basically give rescue breaths and also can help rescue you if you say you failed an intubation. So if a patient has a very difficult, say it's impossible to ventilate with this, you should be really thinking about getting backup when you're trying to intubate, because if you give them medications to intubate and you can't bag valve mask ventilate them, they can die. So very important. And then there's the supraglottic airways. Now I'll talk about really only one that we use more commonly nowadays is the laryngeal mask airway, which is basically in people that are difficult to ventilate using the bag mask valve. This is a way to bypass that. It's a tube that goes into the glottic inlet, and it basically allows you to ventilate through it. So, but this is only really useful for patients that are obtunded, people with intact, say, gag reflex that can vomit. So, and there's other multiple advantages to using that. Basically, you can get a pretty good seal with the laryngeal mask airway compared to the bag valve mask. So if you have this and you're trying to rescue somebody that's got respiratory depression, when you have access to an LMA versus a bag valve mask, I probably would just go ahead and reach for the LMA because, again, it's better higher rate of successful ventilation with the LMA, less fatigue. And one of the other thing, the biggest advantage really is the gastric insufflation. So the esophageal sphincter tone has a opening pressure of about 20 cm H2O. If you're doing the bag valve mask, you can be delivering up to 30, 40 of pressure, and you can be opening the esophageal sphincter and you can insufflate the stomach. Well, with the supraglottic airway, you can basically sort of isolate the glottic inlet and prevent that gastric insufflation so they don't vomit. So that's one of the benefit. And also benefit, you can also even save an endotracheal intubation with this because you can a lot of times successfully ventilate them to the LMA. And one of the biggest advantages is that you're not going to cause trauma most of the time with the LMA versus the endotracheal intubation. Some of the biggest disadvantage there is that it can be dislodged. So a lot of patients that need to be transported, say you're in the emergency room, There needs to be in a rural area that you have got a patient that you got to transfer. It's very difficult to transfer them with an LMA because they can get dislodged, and you don't want to have a dislodged LMA in the ambulance or the helicopter, because those patients are difficult to intubate and they can die. So very briefly about non-invasive positive pressure ventilation. Only really useful for patients that are able to breathe spontaneously. So patients that are obtunded, that are requiring definitive airway, this is a very limited utility. But it's a way to rescue somebody with hypoxemic respiratory failure and save them an intubation. And again, there are a number of contraindications. The biggest thing is a patient vomiting, because again, you can insufflate the stomach and cause them to vomit more, and they can aspirate and they can die from that very, very quickly. So finally, endotracheal tube. There are different parts, different types of endotracheal tube, but this is the simplest one. Basically, it's a tube. It's about 26, 27 centimeters long. It's got a cuff. Whenever you're inflating this cuff, try to make sure that you limit your cuff pressure to about 20 cm H2O, because if you insufflate it too much, you can cause tracheal necrosis. And the most common size that we would use in females are about 7 to 7.5 millimeters, and in males, 7.5 to 8. And I added a chart in here just in case you've got a pediatric patient. There's different sizes. And this chart is useful because it also shows you the laryngoscope sizes that you can use. So whenever you're intubating with an endotracheal tube, really important that you don't curve the endotracheal tube too much. Unfortunately, a lot of our RTs that are, was trained maybe 10 years ago will give you an endotracheal tube that's like a C. And you're trying to intubate with a C, like endotracheal tube, it's not going to work. You got to make sure that you keep the endotracheal tube straight and just a little bit of a curve in the cuff. And you'll notice this if you're intubating. If you've got an endotracheal tube that's too bent, when you're trying to push it in, it's going to get caught in the oropharynx, and it's not going to advance. But if you have something that's a little bit more straight, it's easier to put pressure on it and to advance it into the trachea and into the larynx. So there are two types of laryngoscopes. There's actually like 10 types of laryngoscopes, but we're going to talk about the two most common. The McIntosh blade is the one that I prefer. This is the blade that's a little bit hyperangulated, and it goes in front of the epiglottis and into the vallecula. The biggest advantage of this laryngoscope is it's wide. It's got a wide blade, and it's also got a high flange. So if you put this in someone's mouth, you have a better view of the airway, versus the Miller blade. The Miller blade is very narrow, and it's got a small flange, and it's really only useful for peds. So in adults, there's 4 sizes for the MAC. Most of the time, we'll use the size 3 or size 4. And then in the Miller, it goes all the way to size 5. But most of the time, we'll use 3 and 4, but in peds, we'll use a size 1. And then there's a video laryngoscopes, and more and more, this is something that we would use as a primary method of intubation, only because there's multiple advantages. You don't have to crank the neck so much. You've got a really good visualization, and everyone else in the room can also kind of help with the intubation and tell you whether you're in the right place or not. So also it's just a much better way of intubating, really. Less trauma to the patient's oropharynx, and less force that you have to put. And then one of the other things that we're seeing a lot more, even in the pre-hospital setting, is fiber optic laryngoscopes and bronchoscopes. These are now readily available, about $1,500. You can buy one of your own. And it's really useful for patients that have difficult airway, because you don't have to do a lot of put a lot of force into their airway if you're trying to intubate. And again, you can visualize, and you can do a number of different maneuvers with this in patients with difficult airway. but it requires a little bit of training. And then the other thing that I like is the intubating stylet. Basically, it's a stylet that's got a camera at the very end. So again, this kind of is advantageous in patients with a difficult airway where you cannot move their neck or their mouth opening is very limited, because you can introduce the endotracheal tube without much pressure or neck manipulation. It's about, I think, $2,000 to $3,000 reusable. It's useful if you're intubating a lot in, say, in a rural setting. And then the thing that you should have is a endotracheal introducer called a bougie. Basically, it's a plastic tube that you can use to introduce the endotracheal tube using the Seldinger technique. Basically, if you have a difficult airway, you can use the bougie to go into the trachea, and then you can then use that to introduce your endotracheal tube. So say a patient with a difficult airway, very useful. And then whenever you're working out there, you should always have an airway card. You should know what to have on there. You should have the oropharyngeal airway, the nasopharyngeal airway, a bougie, at least four sizes of the either MAC or the Miller blade, the handle, a bag valve mask, a colorimetric device, and a Young power, and then the 10 cc syringe to insufflate your ET tube. And then sometimes it's useful to have what's called a McGill forceps, just in case they have something in their airway that is causing an obstruction. And then all sizes of the tubes, peds, say size 0 all the way to size 8. And then also useful to have a cricothyrotomy kit, just in case you have a failed airway and you need to do this. I just attach like a kind of simple way to do a cricothyrotomy. And in that kit, you should have at least like a size 6 endotracheal tube, the scalpel, and a tracheal hook. So say you identified a patient that's in respiratory failure who needs a definitive airway. The first thing that you need to determine is this patient crashing? So we'll go through the crash airway algorithm in a little bit. If they're not crashing, if they're otherwise stable, they need to determine, is this a patient that can be intubated orally? So they don't have traumatized mouth, upper airway, or they don't have like a bad angioedema, or say a big tumor causing obstruction in the mouth. Then, but if they do, then this is considered a difficult airway, and you should try to avoid intubating that on your own, and really try to get somebody that can help you, just in case they need a surgical airway. And one of the other things that you can try and do is what's called a nasotracheal intubation, using a fiber optic laryngoscope or bronchoscope, where you're basically putting the tube into their nose, but you're guiding it into the airway using the fiber optic scope. But if they don't have, if they're able to be intubated by mouth, then you need to try to figure out, is there something in their larynx that can cause you to have a difficult airway? Say they have like a laryngeal mass, vocal cord dysfunction, big epiglottis, then you should try to probably intubate this patient with help from somebody, either anesthesia, doing what's called awake fiber optic laryngoscopy, or fiber optic intubation, or basically go straight into a surgical airway. But if they don't, and you need to assess them for difficult airway, and we'll go through the difficult airway algorithm in a little bit. But if they're not a difficult airway, you've done your lemons, all the measurements seems to be okay, they're otherwise stable, not crashing, then you can do what's called the RSI, and we'll talk about that also. So in the crash airway algorithm, they're dead, essentially. So you just go ahead and try to intubate them, try to give them maybe a little bit of succinylcholine, just so that you can try to relax them and improve your intubation. But if they're having a difficult airway, then try to prolong that, try to avoid intubating by yourself as much as possible. Call for assistance is the very first thing, but if you've got no assistance, then go ahead and try to intubate them using RSI. And hopefully you get it the first time. If not, there's a failed airway algorithm we'll go through in a little bit. But if you're trying to prolong this with valve mask ventilation and it's unsuccessful, then try to do it with a wave technique using either a fiber optic laryngoscope or with a direct laryngoscope or regional laryngoscope with adequate amount of airway topicalization with lidocaine or ceticaine. And if that doesn't work, then you can use the supraglottic airways or fiber optic laryngoscope if you can do that on your own, or surgical airway. So if they're not a difficult airway, they're not crashing, otherwise stable, and then you've got all the equipment available to you, then you can do the rapid sequence intubation, which is intubation using a sedative and paralytic. So the biggest advantage of this is that you can relax the patient and make the intubation a lot simpler. There are a number of contraindications to it. So say a patient is in cardiopulmonary arrest, or they have, say, a total airway obstruction, they have a traumatized airway, again, reasons for a difficult airway, then you probably shouldn't do RSI. And also, if you cannot pre-oxygenate them with a bag valve mask, do not do RSI. The P's of the RSI basically. So basically, RSI is you should aim for a 10-minute procedure, and first you have to do you have to plan for it. So once you've made a decision that this patient is qualifies for RSI, you need to let your nurses know. You need to let the RT know so that they can get all the equipment ready. So basically, your airway card, your crash cart, and everything, your medications. So that should be about 10 minutes before intubation. You should prepare for that. So once you have a plan, then you need to make sure that the patient is adequately resuscitated, because RSI, you're basically giving them a sedative and a paralytic, and a lot of times those patients cannot tolerate it and they can crash. So make sure that they're adequately resuscitated, make sure that their shock index is greater than 1, shock index is less than 1, basically that their heart rate is less than their systolic blood pressure. Make sure that you can bag mask ventilate them using the bag valve mask so that you can pre-oxygenate. And then make sure that they're properly positioned, and we'll go through the proper positioning in a second. So next step is to prepare. Make sure, again, you have you have assistants with you. You've got all your equipment on your bedside, and you've got like backup ways of intubating a patient should you have difficulty intubating them. You've got a bag valve mask that you've assessed their neck for cracothyrotomy if you need that. And basically, the most important thing of RSI is that you've prepared. You've got all your backups. So if something goes wrong, you're not having to look for the backup mechanisms that you have to do. You're ready right then and there so that the patient doesn't crash while you're trying to intubate them. There's a checklist that I included in the PDF, very useful. This is the algorithm, and then this is the checklist. Make sure, biggest thing that happens during RSI is that people make the decision to intubate and they don't have the backup. They don't have anything set up, and so you're trying to intubate and you don't get it the first time, and then the patient's desatting and they die while you're trying to intubate. So positioning. Really important in adults that they have at least 10 centimeters of like padding in the back of their neck. This is what's called a sniffing position. Most of the time, I see people trying to intubate with the patient flat, and that's what happens whenever you're coding somebody. They're basically completely flat, and you're going to try to intubate, and you're not going to see the larynx. You need to put at least 10 centimeters, like a couple of blankets or a pillow. And then you need to, once you have that, you have to extend their neck at least 15 degrees to kind of open up the airway. And if that's not adequate, you can lift their head up. It's called dynamic head elevation. You can literally grab their head while you're trying to look at their airway, and try to elevate it up or down. See whether that helps with your that helps you kind of visualize the larynx. And then in this cartoon, the assistant will sometimes help you with what's called external laryngeal manipulation, basically trying to manipulate the larynx so that you can see it. But this is the most important thing, is has to have something behind their head. Otherwise, you're going to be trying to look at their larynx. You're going to try to traumatize their airway, trying to crank that laryngoscope without ever seeing the laryngoscope. Very important. Ever seeing the larynx. And then again, most of our patients now are obese. So the biggest, most important thing is what's called the ear to sternal notch positioning. Basically, you do what's called a ramp. You put a lot of more than 10 centimeters padding behind their head and behind their shoulder blades to elevate their head so that their ear, the tragus, is at this level of the sternal notch. This is the only way that you're going to see that larynx. The airway. If not, you're never going to see it in these obese patients. And one of the things that we've been kind of trying to experiment with is what's called a back half head elevated position. Basically, you're intubating them at 45 degrees. And there's a number of advantages to that. Basically, the gravity will help open up the airway and also the lungs. You're able to expand it because with all this soft tissue here, you're collapsing the lung. But if you're having them at 45 degrees, it's at least alleviating that pressure and help open the lung. So whenever you're bag mass ventilating them, you're deoxygenating them, very advantageous. It's not the standard of care. And again, you can't code somebody in this position, so it's really only in patients that are stable, but it's a way of positioning the patient. And in pediatrics, little kids less than 2 years of age have a big occiput, and it can cause them to flex their neck. So very important to put at least 2 inches of padding behind your shoulder blades in kids below 2 years of age. So in patients with suspected spinal trauma that are in a backboard with a C-collar, really important that you open up that C-collar when you're trying to intubate, and you have somebody either in front of the patient or behind to kind of maintain inline stabilization. And at that position, you can also do the jaw thrust maneuver without having to really flex or extend your neck. And whenever you have, say, suspected spinal trauma, with inline stabilization, you probably should go ahead and try with the fiber optic laryngoscope. I mean, with fiber optic or with the visual laryngoscope as your primary method of intubation to prevent flexion and extension of the head. So things to avoid is neck overextension. If you can't see it, one of the things that a lot of people do is overextend the neck, and that's really just going to push the airway forward, and you're not going to see it. Again, do that dynamic head elevation. You basically, with your laryngoscope, trying to open the head. Try to grab the occiput and move the head, flex or extend, and not do the overextension. And then when you're doing RSI, one of the things that is optional is the pre-treatment. You can pre-treat them with lidocaine. Lidocaine will help blunt the increased intracranial pressure that people might experience when they're intubating, because when you're intubating, when you're introducing that laryngoscope in the back of the throat, that can cause a lot of gag reflex, and it can cause the intracranial pressure to go up. So say, earlier, somebody with an epidural hematoma, subdural, or any kind of mass, and you might want to try to pre-treat them with lidocaine. And then also you can try to treat them with fentanyl as long as their blood pressure is stable, so that they're not going to have that gag reflex, increased heart rate, increased blood pressure when you're introducing that laryngoscope. And you can also try to pre-treat them with the vecuronium. Again, all to decrease the increased intracranial pressure that could happen with the introduction of the laryngoscope. And in children, very useful to have atropine because with children, they have that vasovagal reaction to the laryngoscope being introduced into their throat, and they will brady and they will code. So give them atropine at least 3 minutes prior to the attempt of the laryngoscopy. And also very useful in patients that are receiving ketamine, because ketamine causes a lot of hypersalivation that can make your airway visualization difficult. So another reason for atropine pre-treatment. Next thing is that about 5 minutes before you try to intubate is at least 5 minutes of pre-oxygenation. So this is Rich Levitan kind of demonstrating the what's called apneic oxygenation. Basically, when you're trying to pre-oxygenate, put a nasal cannula in their nose with underneath the face mask, because what this does, it pushes air into the airway. It prevents them from inhaling back the CO2, and it actually provides a little bit of what's called PEEP, and also a reserve of oxygen in their airway whenever you're doing that. So once you pre-oxygenate, we've pre-treated the patient, they're well positioned, you've got all your backup, then you go ahead and do the induction, basically giving them the sedative to make them relax so that you can do the laryngoscopy. And there's 3 main medications that you can try and use, and they have different advantages, disadvantages. I personally really like the etomidate because it's a rather fast-acting, it's short duration, and it doesn't make the patient apneic as much, and it doesn't cause hypotension. Very useful in trauma and sepsis. The only problem with it is that there's theoretical risk of adrenal insufficiency, but you only see that with continuous infusion. With one-time induction with etomidate, you don't really see it. And also there's risk of myoclonus, and the problem with that is that if they're having these myoclonic jerks, their chests can get a little bit rigid and it can be a little hard to intubate them, or their jaw can spasm. So I've seen that maybe twice. I saw that last Saturday. And then the other thing is propofol. Propofol is fast-acting, short duration, really useful. The problem with it is that it can cause a lot of hypotension, but it's available. And then the other thing that a lot of people use nowadays is ketamine. Ketamine doesn't cause apnea, it doesn't cause hypotension. Problem with it, it can cause elevated heart rate, elevated blood pressure, so in patients with increased intracranial pressure, it's contraindicated. But it's very useful in patients that have asthma because it's bronchodilatory. And then after induction, you can paralyze. There's 2 common paralytics that we use here in America, succinylcholine and rocuronium. 50-50 of ER docs use succinylcholine and rocuronium. There's advantages, disadvantages. I'm using more rocuronium now because it's more readily available and it doesn't have as much side effect. With succinylcholine, it's a depolarizing medication. The advantage is that short-acting. The problem is the hyperkalemia. So you have an obtunded patient or somebody that's been found down, you don't know how long they've been down, you don't know what kind of medical problems they have. It can cause significant hyperkalemia and neuromuscular disease in patients with spinal cord injury, in patients that have crush injury. So if you cause that hyperkalemia, they can code. I've had one case where their potassium went to 8, and thank goodness they didn't code on me, but it can do that. With rocuronium, you don't have that hyperkalemia. The problem with rocuronium, though, is that the duration is a little long, and the onset is a little long. So this is just a table for you to kind of a little mixture of medications that you can use depending on the scenario that you're presented with. And then this is a little bit controversial, but we used to get taught that you have to induce the patient before you paralyze them because you don't want them to be aware of the paralysis. It's very traumatic. they're at risk for post-traumatic post-traumatic stress disorder afterwards because they're paralyzed and they're aware of it. But if you're using ketamine and rocuronium, which is the most common induction paralytics that we use now, the onset of effect of the rocuronium is so long that if you just go ahead and give it, if you give the ketamine works a little bit faster. So by the time you give the rocuronium, by the time it's starting to work, well, the ketamine is also starting to kind of work a little bit. So what we recommend is giving the rocuronium first, because that takes a little longer for the onset, and then giving the ketamine afterward, because their peak will kind of match each other at say 60 seconds. Also, if you're going to give these medications, wait at least 60 seconds before you try to intubate, because if you try to prematurely intubate them without having maximum effect of the rocuronium, maximum effect of the ketamine, the patient will gag and they will vomit, or they will bite the laryngoscope and injure themselves or injure you. So make sure that there's a nurse that's kind of timing. Once it has been given, wait at least 60 seconds. Once you've done all of that, the placement of the endotracheal tube really should be straightforward. If they're properly positioned, they're relaxed, and they're well pre-oxygenated, they have a lot of oxygen reserve, then placement of endotracheal tube is the easiest thing you'll do. Basically, you open the mouth and you introduce the laryngoscope on the right side of the mouth, okay, all the way to the right. And then you do what's called epiglotoscopy, where you slowly advance the laryngoscope until you see the epiglottis. If you're using a Mac blade, then you put that laryngoscope in front of the epiglottis into the vallecula, and then you then pull. Don't crank. You pull onto the on the jaw to kind of help open your airway. If you're using the Miller blade, then you go behind the epiglottis, and then you lift the epiglottis up. And then you go ahead and have somebody hand you the tube. Very useful to have somebody kind of opening the right side of the mouth, just so that the endotracheal tube goes in a little bit easier. And then you watch it go past the vocal cords until at least 23 centimeters in men and 21 centimeters in women. There's a number on the endotracheal tube that will tell you what depth you're in. So things to avoid is putting the laryngoscope in the middle of the mouth, because what happens, even if you've got a Mac, the tongue will drape over and it will completely occlude your view. Or if you're not all the way to the right, again, or if you're not pushing the tongue all the way to the left, it'll occlude your view. So very important to put it all the way to the right and then push the tongue all the way to the left. And then some of the people will tell you to put the laryngoscope all the way down, and then you just kind of retract until you see the epiglottis and the vocal cords. Problem with that is that you can go all the way down to the esophagus, and sometimes the esophagus can look like your airway, and you can inadvertently intubate the esophagus. And also avoid rotating the laryngoscope, because you can break the teeth. The problem with that is if you break the teeth and they aspirate it, then you've got a foreign body in the airway. Once you've intubated, then you need to make sure that the placement is good. You can use a colorimetric device. It should change from purple to yellow if you're in the proper airway, or you can attach what's called an end-tidal CO2, and then you should see how much CO2 is being expelled during exhalation. It's normal for that is 35 to 45, and then should auscultate the lungs. Make sure that you're not doing what's called a right main stem intubation, and then you get an X-ray. An X-ray, the endotracheal tube should be about 5 centimeters above the carina, plus minus 2, depending on whether the neck is flexed or extended. So once you've intubated and you've confirmed placement, Very important, don't walk away from the patient. You need to make sure that the endotracheal tube is well positioned, that the head of the bed is elevated so they're on aspirate, and that you're making sure that the cuff pressure, what we talked about earlier, should be less, 20 centimeters of H2O, and that you're getting an ABG, making sure that the chest X-ray is obtained and that everything is properly positioned. So say you did an RSI and you didn't get the intubation. So what you can do, you can try at least 3 times with direct laryngoscopy, and then you probably should go ahead and move on. If you can't do the video laryngoscopy, or you can just go to video laryngoscopy in the first place. And if you can't intubate that way, then you use those supraglottic airway like an LMA, and you go ahead and try to bag valve mass ventilate them through that. And if that fails, well, then you have to do a cricothyroidotomy. One of the other things that we would do is the delayed sequence intubation. Sometimes kind of, say somebody who's agitated but needs to have an airway, you have to kind of sedate them a little bit, make sure that they're well pre-oxygenated before you try to intubate. So that's that. Any questions? No? So once you've intubated them, now what to do with the mechanical ventilator? Well, mechanical ventilation is really just delivery of positive pressure to the airway. And again, the main goal is to oxygenate or clear the CO2 and protect the airway. Again, similar reason that you would intubate would be the reason for mechanical ventilation. So some of the most important concepts in mechanical ventilation is knowing the airway pressure. Airway pressure is really important because if you give too much pressure during mechanical ventilation, you can really injure the lungs, you can injure the airway, you can cause shock, you can affect their blood pressure and they can code and die, or you can worsen their disease, say in asthma or COPD. And airway pressure is the summation of the peak airway pressure is summation of the airway pressure and the alveolar pressure, and those two are really affected by the say compliance of the lung. Compliance is the lung's ability to expand, and of the resistance of the airway. So this is what we're trying to prevent. Reason why it's so important to know the airway pressure. Again, with excessive airway pressure, you can really destroy the lung and really injure the patient. And the reason you do that is basically you injure the alveoli, and that can cause a lot of inflammation, and it can cause a pulmonary edema, and it can cause what's called acute respiratory distress syndrome, or ventilation-induced lung injury. So tidal volume is the amount of air that you breathe in and out normally, in the normal spontaneous breathing, and minute ventilation is the total tidal volume over 1 minute. So tidal volume is determined by the patient's height, and so this is this chart that can help guide you when you're trying to set the mechanical vent and how much minute ventilation you should give. So, like we talked about earlier, one of the most important concepts in mechanical ventilation is compliance. Compliance is, again, ability of the lung to expand, and this is determined either by the lung itself or the thorax. So, if you have a patient who has emphysema, their lungs can handle large amounts of volume, and so you can have really high compliance. So you need to be very aware of that so that you don't deliver too much volume in those patients with emphysema, and that you're letting them basically have good recoil. And compliance is decreased in patients that have restrictive lung disease. So say idiopathic pulmonary fibrosis have decreased compliance, and also patients that have edema or severe inflammation of their lungs, those lungs are not going to be able to expand, and so they have really decreased compliance. And the reason to know about that is because you can have elevated airway pressure, even if you're just delivering the normal amount of tidal volume. And we'll talk about why that's important in a second. And then this is the reason we get concerned about it. It's called auto-PEEP and dynamic hyperinflation. So in patients with airway obstructive disease, like say COPD or asthma, if you're giving them large amounts of volume and you're not, and their lungs can be very distensible, you can keep delivering volume over and over and over until you reach the maximum amount of volume that lung can accommodate. And if you deliver more, you can cause a pneumothorax, you can cause a barotrauma, you can increase the intrathoracic pressure, and when you do that, the venous return to the heart can plummet, and they can have circulatory collapse, and they can code and die. So also, these people have what's called auto-PEEP. Basically, if they're having what's called auto-PEEP, they're not exhaling the amount of all that air, and they have pressure, remaining kind of stagnant pressure in their lungs. So very important that you let these patients exhale, and also to limit the amount of tidal volume that you're delivering. So resistance, basically the anything that can cause any obstruction in the airway. It can be intrathoracic, say in patients with asthma or COPD, or exothoracic in patients with, say, laryngeal edema, or tracheal hematoma, or any kind of tracheal mass. It can increase their resistance, and what happens is that when you're delivering, say, a breath, their peak pressures will go up very rapidly, but that doesn't necessarily mean that their plateau pressures, the alveolar pressure, is going up. It's just the resistance is causing the peak pressures to go high. And that has implications on how you ventilate these patients. We'll talk about that too. So mechanical vents, they have basic, all of them have this general setup. Basically, the machine delivers oxygen through the inspiratory tubing, and they all usually have an humidifier. And then that same tube, and then they have an exhalation tubing with a valve that prevents the CO2 from being breathed back by the patients during inspiration. So most of the vents have this monitor, and I want to talk about what they all mean. So basically, it'll talk about what kind of ventilation mode you're in. It'll give you what kind of pressure is being exerted onto the airway, what respiratory rate the patient is having, what fraction of oxygen the patient is receiving, and the total minute ventilation they have based on the settings that you place. And these are the settings that you usually will change. And then they usually have different waveforms. This is the pressure time waveform. So when you're delivering a breath, the pressure goes up to a certain point that you target, and then once that you reach that pressure, you stop the breath, and then let them exhale, and the pressure drops. And then again, the flow time is similar. When you're initiating the breath, the flow goes up to this certain amount of flow that you want the patient to receive, and then it stops, and then the volume obviously goes up with the inhalation up to a certain amount of volume, and then they exhale. And then it'll also show that pressure volume loop. The pressure volume loop is very useful when you're trying to kind of estimate compliance in this patient. The compliance, I think I'll talk about that. The compliance can be elevated. We talked about can be elevated in patients with COPD. So you'll have this kind of volume loop all the way to the left, or if they have really low compliance, it'll go down to the right. And it's because the amount of volume that you deliver, the pressure can be low if the patient is very distendable, but the amount of volume causes increase in pressure, really high if they have really low compliance, and then the pressure and then the flow volume loop. About that, yes. So the again, phases of mechanical breathing. There's the inspiration that can be either patient triggered or machine triggered, depending on whether the patient is apneic or not. So patient can initiate breaths during mechanical ventilation, and then the machine, depending on the mode that you're giving, will then initiate a breath. But if they're completely apneic and they're not breathing, the machine can trigger a breath also. And then there's the inspiratory phase, where basically the rapid ramp up of the pressure during the beginning of the inspiration, and then there's the plateau phase when you're delivering the volume, and then the expiratory phase. So these are the waveforms that we were talking about earlier. Kind of useful a lot of times if you're troubleshooting the patient or if they're decompensating on the mechanical vent. And then the flow volume loops, kind of what we talked about. Similar to pulmonary function tests. So say a patient has an intrathoracic pressure, then their flow volume loop and the mechanical vent can look like this, where they can inhale, but they can't exhale very efficiently. Or if they have some sort of fixed area obstruction, say laryngeal tumor or tracheal mass, they can't necessarily efficiently inspire or exhale. So this is what their flow volume loop on the mechanical vent may look like. Or if they have restrictive lung disease and they can't pull in that normal volume, then they can have low volume but normal exhalation and inhalation efficiency. So, and then this is the pressure volume loop we talked about earlier. So this is your pressure volume loop in spontaneous breathing, but if you're in a mechanical ventilator, you're having to introduce pressure during each breath. So whenever you're giving volume, the pressure goes up. And usually this is about 4 to 5 degrees. And when you're exhaling, then the volume goes down and the pressure goes down. In patients with increased compliance, say in emphysema, then you can deliver volume, but the pressure doesn't really change all that much because they're very distendable. So it'll cause the compliance on the curve and the pressure volume loop to go to the left. And in patients with decreased compliance, say in pulmonary edema or ARDS or CHF or pneumonia, their lungs are not very distendable, and it can cause the pressure to ramp up very, very rapidly if you're whenever you're introducing volume. So this can cause the compliance curve to go down to the right. So types of mechanical ventilation. There's a number of ways to group them, but the way I like to group them is a volume cycle and pressure cycle, the flow cycle. In volume cycle, basically each breath is determined by the amount of volume you want the patient to receive. So the initiation, the termination time of that volume is dependent on the initiation and the termination time of the breath is determined by the amount of volume you want that patient to receive. In pressure cycle, this is the initiation time and the termination time of the breath is determined by the amount of time you want the patient and the amount of pressure you want them to receive. And in the flow cycle, this is kind of we'll talk about it in a second, but it's the flow is the amount of time that you want the patient to breathe depends on the amount of flow that they're pulling in and exhaling. So types of mechanical breaths, volume control is whenever the patient is apneic and they're not triggering any kind of breath at all. So the machine will deliver a breath, and that's called control. But if the patient is able to trigger a breath, then the machine will recognize that breath and deliver the volume that the volume that you set. In pressure control, similar concept. The patient is usually apneic and they will not trigger a breath. So the machine will then deliver a breath, but the breath is usually determined by the amount of pressure and the amount of time that you want them to breathe. And then in pressure assist, the patient is not completely apneic, they have a respiratory drive, they will trigger a breath, and then the machine will then deliver a breath